Well, welcome back to MentorLIVE number 98. We're so glad you're here. My name is Aaron Dabney. I serve on your board of directors, and just welcome back to this free public service that NAFI brings you every month. I know we had maybe a little bait and switch this month with the host. I am not Dr. Victor Vogel. He wishes he could be here tonight, but he had some things come up that were unfortunately unavoidable. And I'm fully aware that we might be shortchanging you a few IQ points tonight, but we'll get through it. Stick with us, I promise. I've got a great guest for you, though. Dr. Pinnell will make up for that in spades. This is going to be a really good one, current hot topics in FAA medical certification. We've got two really good specific topics for you tonight. And when Dr. Pinnell grabbed me at Oshkosh and said, hey, we need to do this, I said, oh, yeah, people want to hear about this. So I think that you're going to get a lot out of this evening. So glad you're here. A few housekeeping issues as always. Just like all of our presentations, this is eligible for wings credit. So make sure you click the button there under the broadcast window. Wait until we're done. Watch the presentation first, but click the button, answer those 10 simple questions, get your wing certificate, show your friends, make sure they're here next time. Of course, you can find information about the topic and our presenter this evening. And there's that link right there at the bottom, Join NAFI. As you know, you don't have to be a NAFI member or even a flight instructor to be a participant in MentorLIVE. And you also don't have to be a flight instructor to be a NAFI member. As long as you care about advancing aviation safety through quality instruction, we want you as part of NAFI. So please consider joining. As always, we want you to interact with us here on the live portion. So Dr. Pinnell has agreed that just whenever we have a good question come up, and I know we're going to have some this evening, I'm going to jump in and interrupt him for a moment and let him hold forth a little bit on your questions. So make sure you ask those good questions. Just as a reminder, there on the bottom of your broadcast window, you see the little thought bubble. Click on that first to join the chat room, but make sure that you give us your name first and then ask your question. We don't want to be addressing you as the first few words of your question. I want to show you one more thing that we've made available the past few months here. Many of you probably got to make the very first NAFI Summit we had in 2023, but if you didn't, we've got a little over 28 hours of really good content out there that you can consume for free. All you've got to do is click that QR code there and go take a look. There's some excellent stuff there by some excellent presenters, and we really want you all to be able to take advantage of it. So without further ado, we're going to bring Dr. Pinnell on camera again, current hot topics in FAA medical certification. So I get to introduce him to you, and then I'll turn it over to him. Greg's been a pilot for 42 years and a medical examiner for 25 years. He's a family practitioner, senior HIMSS AME. Here's some pretty cool stuff. Former chief flight surgeon of the Aerospace Medicine Squadron at Grissom, and former deputy chief of bioastronautics, which I did not know was a thing until I was working on his biography. That is cool, for human spaceflight support. He's an adjunct prof at Western Michigan, president of the Civil Aviation Medical Association, a fellow of the Aerospace Medical Association, a member of EAA's Aeromedical Council, and a consultant to Federal Air Surgeon. So, Greg, I think you know some stuff, and I want to turn the controls over to you.
Sounds good. Appreciate it. And can you hear me okay? How's the volume? Fantastic. Well, welcome everybody that we've got online for this. This is what we're trying to do tonight is we're trying to hit a couple of the topics that we run into on a regular basis. We are high volume flight medicine practice, and so we see a lot of student pilots. And one of the problems that we've run into is the young student getting up to solo time and all of a sudden getting in for their AME exam and finding, oh boy, now we got to slow them down because they're not quite ready for it because we've got some issues to deal with. And what I'm hitting tonight are two of the big ones that we see, probably the most common ones, with the color vision being a little bit more recent, as the color vision testing changed as of the 1st of this year. So, like I said, what we're going to talk about is obstacles. We're going to talk about attention deficit and hyperactivity disorder, which is what we see in a lot of kids with that diagnosis, and attention deficit disorder, which we see that more in adults. And yes, we do see this in student pilots who have decided later in their life to be pilots. We're going to talk about a treatment. We're going to talk about the obstacles to certification that we run into and what is acceptable to the FAA. Then we're going to hit color vision. Now, color vision historically has been, the plates or the Farnsworth lantern. We've had these tests around for probably more than any of us have been alive. And as of January 1st, 2025, the FAA changed the rationale and changed the testing to a couple of computer color vision tests. We're going to leave out the reasons for that. That would take a little too much time to go into that, but we're going to talk about some of the problems that we've had with that. So let's talk a little bit about definitions. What's attention deficit hyperactivity disorder and attention deficit disorder? It's a very common diagnosis. We will run into it in new pilot applicants almost every day. If we skip a day, we'll get to the next day. The biggest thing to remember about attention deficit disorder is it's not a mental health diagnosis, okay? For those of us who do MedExpress on a regular basis, there is a question in section 18M for mental health diagnoses. ADHD is not a mental health diagnosis, it's a developmental disorder. Although we generally don't outgrow it as we get older, as our brain starts to mature, we usually come up with some workarounds. Now, the thing about attention deficit disorder and the other corollary, attention deficit disorder, they don't exist in a vacuum. Sometimes we find them isolated, but sometimes we find them in concert with other disorders of mental health, such as mood disorder, autism, their Asperger's, other learning disabilities. We can find them together. And sometimes that means there's going to be a lot of teasing out to be able to deliver a safe pilot into your hands for the purpose of flight training. Now, these can be diagnosed at various different stages of life. Probably one of the more common scenarios is little Joey's very fidgety in the room. He can't stay in his seat. He can't pay attention in class, and the parent or the teacher or both say, well, there's something wrong with little Johnny, and now we've got to find out what's going on. But basically, we see it mostly at an early age. Like I said, inattentive or sometimes overactive behavior, sometimes even disruptive behavior too. Now, the thing about disruptive behavior is it's not necessarily ADHD or ADD. That can be some other things too, but of course, that's our job to figure that out. But in any case, the patient's brought in by the parents, usually maybe with a little bit of note from the teacher or maybe not, basically to the primary care or psychologist or psychiatrist and saying, well, something's wrong. Little Johnny can't stay in his seat. He's not doing well in school. So some evaluation needs to be done. And the testing for that, we see it all over the place. We will see everything from simple screening tests to, anecdotal comments from the teacher about how he's doing. Sometimes we'll see very comprehensive testing done, although that's more the rarity of it. And unfortunately, sometimes it's what we call a diagnosis of convenience. Nobody's happy with how little Johnny's acting, so we decide we're going to do something about it. There's tons of different screening products to test them for, and there's tons of different products for the teachers to test on it. Sometimes that gives us a decent idea whether we've got a diagnosis. Sometimes it does not. Truly diagnosis, a formal evaluation needs to be done usually by the psychology folks. But we get all different forms of testing and sometimes no testing at all. All right, so whatever the testing was done, now somebody says, okay, little Johnny's got attention deficit disorder, attention deficit hyperactivity disorder. So what usually happens? Usually it's medication. Probably you've heard about a lot of these, Ritalin, Adderall, Strattera, Concerta. There's a bunch of them. Now, the thing that comes up, and one of the questions that we get is, if little Johnny's doing better on these medications, why can't we just fly him on these medications if he's doing better? Well, one of the problems with that is that there are various different levels of compliance with medications. It is not infrequent that the patient, I'm going to use that term as we go along here, the patient forgets doses or goes on and off the medication as a convenience. Sometimes, and this is one of the more common ones, they go on it for only the school year, and they'll take vacation from the medication during the summertime. Sometimes they'll only use it for taking tests. And that's another story, particularly with some of the more common tests like the law tests and some of the medical tests, whether medication should be allowed or not. But sometimes it's continuous. He or she takes it every day. So it can be all over the board. And the problem with that is it's really hard to let them fly with the diagnosis and on medication because we never know whether they're going to take it or not. All right. So then, the little Johnny gets older, all right, and sometimes his frontal lobe, the executive portion of the brain, which is up in the front there, sometimes it matures. And by the way, that part of the brain doesn't mature until we're in our 20s, okay? So it takes a while to mature. Frequently, the patient, in concert with the primary care or treating physician, and sometimes not, they decide to stop the medication. Sometimes they get a little information off the internet and find that, oh my gosh, little Johnny cannot fly on this medication, so we need to stop him on the medication. Sometimes that works, sometimes it doesn't. We've had both. We've had it where in the majority of cases where they come off the medication, they do just fine. And sometimes we've had it after a couple of weeks, the behavior gets pretty bad and the parents say, hey, we got to go back on the medication. So you can see the type of cases we get, it's all over the places. But in any case, our little guy, Johnny, wants to be a pilot. All right, so now they get into our hands and we've got to figure out if this is true diagnosis, do we have something that's aeromedically significant or not? All right. So in the past, up until relatively recently, the FAA has required a pretty significant battery of testing for this particular diagnosis. And one of the things that they've required historically is a full neuropsychological evaluation done by one of the FAA trained neuropsychologists. These are great tests for testing. They give you really good fidelity of how the patient is doing. But here's the problem. They're seldom covered by insurance, if ever, and they are costly. We are talking about $3,000 to $5,000 and sometimes more testing, which we may or may not really need. They're time consuming. And then the other problem we have with them is we have to correlate the results of that formal testing with how they're actually doing in the airplane. Sometimes that correlates nicely. Sometimes it's not that clean. Sometimes it's more messy. And I cannot tell you how many times we've had a patient, student pilot with a diagnosis of attention deficit disorder where we do the full testing. And yes, there's some problems, but we also get a CFI statement, after 4 or 5 hours with the student, and the CFI says he's doing fantastically. If we had more time, I could give you a couple examples of cases that we've seen over the year that were really quite interesting, both positive and negative. So the FAA, to their credit, recognize, there's a lot of applicants out here that probably really don't have a diagnosis or it was remote. So they revised the policy. And this is one that they did a nice job with. They split it out into 2 tracks. First of all, the standard track and the fast track. Now, we're not going to get into the standard track. The standard track is where full testing needs to be done, and we'll get through the parameters of that in just a second. But what we're going to talk about right now is we're going to talk about the fast track. In other words, the track that if we do the work before the AME exam, we should be able to issue this pilot student pilot their medical and not have to delay them. So let's get this next slide. All right, very good. So it's important to remember at this point that, we get people who say, well, I got attention deficit disorder, but I'm off medications now, so I'm all good now because I'm off medication. Now, you got to remember here, it's not just the medication, it's the diagnosis and it's the medication. Now, the length of time and how recently they were treated now becomes a big factor here. For the purpose of this conversation, we're going to look at the type of cases where the treatment was stopped greater than 4 years ago. And that's what we're talking about, the fast track, the one where we may be able to issue this person in the office if we can get some workup done. So what are we going to need? What's the FAA lens? What do we have to look at? All right, first of all, we got to look at the treatment records from the psychologist, the psychiatrist, or maybe the primary care or the nurse practitioner, the PA. So we got to look at those treatment records, and we've got to make sure that what we've got is probably attention deficit disorder and maybe not attention deficit disorder and something else. We also have to take a look at the last 4 years of pharmacy records. There's a couple reasons for that. First of all, to make sure that they haven't had medication in 4 years, but secondarily to that, and not infrequently, we find other mental health medications involved, and we need to know about that as well. Sometimes we actually find substance abuse issues that we have to deal with that's going to complicate the case further. If there were any evaluations, and sometimes we'll get the student pilot coming in at 19, 20, 21 years of age, and the testing that they had was at 5, 6 years of age. There's no way that that's going to be available. All right, so sometimes we have to do without, but a lot of times the parents will put the student pilot through a pretty extensive evaluation, and sometimes we can gain access to that, and that really helps us. Any other medical records that we need of aeromedical relevance? There can be other disorders that we're going to have to worry about. We also, if they are driving, we need a copy of their driver's license and their driver's record. Why? Because we need to see if little Johnny's got a history of losing his driver's license due to speeding, DUI, reckless, other things that may tell us that attention deficit disorder may not be the only thing that we're looking at. We may have some behavioral problems that we have to deal with as well. Finally, the other thing that helps us, we get the transcripts of school. Now, I don't know about you guys, but if you looked at my high school transcripts from community college and the like, you'll wonder, what the heck is this guy doing being a doctor? I was a little bit of a late bloomer on a lot of things, except for pilot. I was a pilot before I was a doctor. Go figure. All right, but we do take a look at those because sometimes it's helpful to see where little Johnny's coming from his grades, and has he all of a sudden improved? Okay, the requirements, all right. What are we going to need from this? All right, first of all, we need a personal statement. We need, and a lot of times we have this done with the student pilot and also in concert with the parents. Put the story together. Tell us how this all evolved. What were the problems that you were having? What were the things that told your parents or the teacher that maybe we've got a problem about it? Were accommodations done? And also, what do you want to do with flying? What's your goals out of this? That's very important. Maybe little Johnny just wants his private pilot license, okay? But maybe he wants to be flying at, an A350 1000, all right? So we kind of got to know what his goals are. We also need to know if there are any accommodations for him for testing in school and the like, such as an IEP or 504 program for them. And again, we need any current evaluations by psychologists, neuropsychologists, or any other provider that's done any form of mood testing, mood or anxiety testing. And honestly, what we see most commonly with attention deficit disorder, we'll see mood disorders such as major depressive disorder, Sometimes we'll see what we call adjustment disorders. Sometimes we'll see anxiety disorders, and sometimes we see panic. Now, as I mentioned a couple slides ago, your input is really important. You are where the rubber meets the road. I know most of you, any good CFI that I've ever met knows within the first hour with the student pilot in the cockpit, is this person going to have a problem or not? I don't know about you, but there was a slide at the very beginning of this, or the video, that talked about dreaming of flying. I don't know about any of you, but I certainly did. From my first airplane ride at Harry Brown Airport, I thought about nothing else other than flying for a long period of time. So we need to know how you feel about them, because we need to measure that against the formal testing that would be done. And then again, any other medical conditions, you know, every once in a while, the youngsters will have a heart condition or something like that, that usually doesn't cause a problem, but we need to know about it. All right, the challenges. Now, this is the foot stomp here, okay, the big deal. We have got, from the time that we see little Johnny, we have got roughly a 14-day window to be able to certify him, or we've got to defer him, okay? We need time to gather this documentation. Actually, the patient needs time to gather the documentation, or the parents. A lot of times we need to talk with evaluating providers. In other words, where we don't have to use the FAA neuropsychologist, where we're going to use a community psychologist or someone who's going to test this youngster. A lot of times we have to talk with them because they don't understand the FAA lens, and we kind of have to explain it to them. Usually pretty easy. We may need to do a drug test on them at the time that they do the testing. We need to, sometimes, to make sure that they're not on amphetamine medications while they're doing the testing. And then, of course, getting the CFI statement from you. Sometimes we need to get them over to an FBO with a CFI and let you spend a couple hours with them and give us an impression of how they're doing. And this takes a little bit of time. So the big deal here is time, and we need to get this information if we're going to have a swing at being able to get this person certified and not have to defer to FAA. Now, one of the things, and I hear this pretty frequently, that people don't understand, that even a person without a clinical diagnosis of attention deficit disorder will, if they take medications like Ritalin and the like, they will have a performance improvement. You don't have to have attention deficit disorder to take a medication and get a performance improvement. Not saying anything, but on the medical board certification test, honestly, I'd like to know how many of the doctors are on these medications, because these tests are a full day. It is a full day of testing, and it is hard to maintain your concentration. And believe me, I've been through them plenty of times, and it's not a lot of fun. So again, important to understand that even if you don't have attention deficit disorder, you take these medications, it will improve your focus. Unfortunately, and maybe a little bit less so, but at least we're trending in the right direction, but I think we're still too quick to start people on medications. There's other treatments that can be done. And historically, the providers are not been really good about stopping medication. Now, they've created some new laws which basically have reduced the amount that we can prescribe and the period of time for which we can prescribe it, which has helped us get a little bit more close follow-up. But at the same time, we're not really good at stopping medications. And a lot of times, the patient stops it on their own, and sometimes in concert with the family. All right, so pro tip on ADHD. And we had this conversation before we started. How do you approach the young student pilot who's coming in for his discovery flight, says, hey, I want to fly for Delta, United, Southwest. What I want to fly for the majors, 121. Okay, that's what I want to do. And I want to get going on this. How do you ask them, hey, you ever been on medications? You got any medical problems? How do you do that with some sensitivity? Well, there's a couple different ways to do it, but it is in your best interest to somehow broach the subject with them in a nice way, in such a way that you can find out whether they need to be in front of the AME sooner rather than later, so we don't delay their flight training. The other thing that and I'm sure all the experienced flight instructors out there have seen this before, there are some of the students that are just not going to get this, whether it's attention deficit disorder or not. Not everybody is designed to be a pilot. Believe me, I know a few physicians who are not the best of pilots. I'm just saying, okay? But sometimes we also need, little Johnny wants to solo on his 16th birthday, and that's really cool. I wish the heck I had. I didn't get my pilot's license until I was 22 years of age. But maybe we need to let little Johnny have a little bit more time to let his brain mature, or maybe we may need to treat him for some other diagnoses related to mental health first and get him in a good spot before we come back around to this. So he may need just a little bit of time. Getting a general impression of how this kid acts in the airplane, hugely important. Now, 99 times out of 100, we'll get the letter back from the CFI saying, oh my gosh, little Johnny's doing great. He's doing exactly what he should be doing for 2-3 hours, and that's fantastic. We have had a couple situations where and one was a phone call, where the CFI came back to us and said, I don't want to get back in the airplane with this kid again. Okay? And we didn't see that coming. Understand, when we see little Johnny in the office, we can usually size them up pretty quickly. We usually know pretty well whether this kid's going to make it or not. But we can be surprised. In this particular instance that I'm telling you about, we were surprised because we thought he would do fine. And the other thing, well, we may want to give them their medical under special issuance. All right? And let's follow them for a couple years. We may need a note from you. We've probably got 5-6 cases of special issuance where the only thing we need on a yearly basis is that you tell us how they're doing. We don't need anything more than that. You guys are the experts, all right? This is
Dr. Pinnell, I've got a question on the CFI statements that I think it might be germane to this point. If I could interrupt you for a second. Lauren says, I'm going through a very similar process for SSRI usage. I haven't seen transcripts or CFI statements as requirements for my process, though in my case, I believe would be beneficial. Are these something I can include in my submission to the FAA, and will they be taken into consideration?
Absolutely. And yes, she's absolutely right. They are not in the list of things, but on the SSRI cases, and we have a ton of them, okay? We are always asking for that CFI statement. And by the way, I might add, sometimes when we're discussing the case with one of the FAA doctors, and we pretty much know all of them, and we're kind of on the fence with how are they doing, how they look, and we'll get the question, what's the CFI say about them? How are they doing? And that's where you folks come in greatly. I mean, you have your eyes on them. I may be seeing them for 30 minutes in the office, but you're seeing them in the cockpit in that left seat with you over in the right. So that's a great question. And yes, ma'am, that should be added to it, all right? Because that really gives us that gives more fidelity to the case.
Well, we're on CFIs. Jack has a good question too, and I'll save a couple more ADHD questions for the end of this section. But Jack wants to know, what percentage of patients are you seeing for medicals right now? You said you see them almost daily, but could you put a percentage on how many you're seeing that have an ADHD or ADD diagnosis?
Of 2,400. Probably we'll see, and I could be slightly under or overestimating. A history of it, we'll see well over 100. Well over 100. Might even be more than that. Boy, that's a great question. I don't have the stat on that. It wouldn't be that hard for us to figure out because we have a special length of appointment that we have to give to that. But It's a good question, but it's not an insignificant percentage.
Excellent. Okay, I've got a couple more, but I'm going to save those for the end of this section when you finish up here.
Go ahead.
Go ahead. I'll save the next
okay, sorry. Well, the big thing I want to do is I wanted to really foot stomp that last point at the bottom there. We may not, if it's looking okay, but we've got some questions, the FAA, Aeromedical Certification Division, may say, okay, yeah, all right, let's give them a special issuance medical. Let's get them started flying. Let's watch them for a couple years, okay? Yearly medical, and let's see how they're doing. And after a couple of cycles, couple years, if they're doing fine, let's put them back on a normal medical, wish them well, and, hope to have a great flying career. So that's an important tool that we use. All right, that's the end of that one. Do we have any other questions we want to roll into that?
Yeah, let's get these. This is from Kevin. Kevin says, during FAA medicals where we're required to provide additional information, like for a special issuance, why can't we upload, basically his insinuation is, what he knows he needs. Why can't we upload that via MedExpress? We already know what's required in advance. And twice I had an AME that didn't upload it. So that fax and certified mail thing is very inefficient to say the least.
So yeah, great question. Okay, so historically we've always, we've mailed them in, we've FedExed them in, we've faxed things in. I've been doing this. I've been doing this since this form was on paper, and this was always one of our biggest challenges. Now, a few years back, they came up with the upload system, and the upload system has gone through a lot of revisions. It's got more work to do as far as file size and number of files that can be uploaded, but it's clearly a move in the right direction. Yeah, there are some AMEs that will not upload. Sorry. There are AMEs who do more of this than others. There are not a lot of AMEs who do this full time with a large volume, but most of the AMEs out there, from what we see, do upload. But there's one other aspect of that: the review and the categorization of this documentation. We don't expect you to understand all the ins and outs of the various types of evaluation and the nuance of that. Having said that, I'm not really good at V1 cuts either, okay? And my slow flight, my speed control is horrible, okay? We all have our lanes of what we do well and what we don't do well. So you're going to have to pick your AME that not only does upload, but knows how to categorize this stuff. We know from the FAA's folks that they've had some problems with this, all right, as far as AMEs uploading stuff and not separating it out into the categories. And we've really, since the upload system came on board, we've really expanded the amount of categories. A bunch of us have made suggestions like, you need this category, this category, this category. The pilot uploading it, honestly, realistically, it's in your best interest to go through the AME on that, because we're just way more efficient at it. And I'll give you the perfect example on this, and then we'll move on. Okay, so the pilot comes in with a stack of documents like that, or that, or that, okay? And they're going, well, here, let me get this for you. Let me get that for you. It's like, no. Give me the paper. Give me the stack. I can go through that stack. I know exactly what I'm looking for. I can pull what I need out of that stack of paper that thick, and I can pull that out in about 3-4 minutes. I've got one case that I've got a box of documentation right now. That case just came in, that big. I will narrow that down from that big to that big. We don't expect you to know how to do that. We wouldn't have a reason to expect you to know how to do that. Does that help?
I think that's fair enough. Yep. So one more question here. I'm gonna read it verbatim because I want to make sure and get all the nuance here. But Dr. Pinnell, I'm a freshman at Western Michigan. My medical took a year to get clear as a result of a couple of months of free therapy for post-trauma. My therapist was on top of notes, and I sent her what was needed right after I was asked. Her diagnosis can be considered one of convenience. I had to put something down, she said. While I got my medical early, I imagine that wait time would have killed my progress as a student pilot had I waited. Do you have any ideas on how to encourage pilots on seeking medical help? How can we utilize the Mental Health and Aviation Act of 2025 for this should it pass?
Great question. All right, the easiest way to answer that is to understand that in some cases, and we run into this in cardiac too, for testing to be there, they have to have a diagnosis in the chart, which I hate to say this, may or may not be accurate at that point. It may be a provisional diagnosis. All right, so that's one thing. The other part about that too, and Dr. Chestnut, who was the chief psychiatrist for the FAA, who has unfortunately passed away not that long ago, he said that the biggest problem that they have with mental health issues is diagnostic accuracy. And we have seen that time after time after time. I will tell you bluntly, I'm board certified family practice. I will tell you, we aren't that good at this. Okay, we are not that good at diagnostic accuracy at this. We're not well trained to do it, number one. And number two, a lot of times we don't have time to do it in the amount of time that we're allowed with that patient. So we need diagnostic accuracy, number one. The FAA understands that sometimes the diagnosis that is there may not necessarily be accurate, but may be revised afterwards. Now, with reference to the time that FAA is spending with cases, the wait time, the review time has come down in some cases, come down pretty dramatically. Congress has kind of put the FAA's feet to the fire on this, and the FAA is doing a pretty good job of bringing that wait time down. It's not perfect, but it just points up getting into the AME early to try to sort the case out. There's a lot of the cases that we see that we will see the person in on consult. We may get their height, weight, blood pressure and the like, but we're not going to have them do Med Express yet. We've got a lot of work to do before we even get to that point. Or we may say, hey, little Johnny needs a few years down the road before he's going to be able to do this. It's a great question, and I hope I gave you some of the right answers for that.
Yeah, excellent, thank you. Let's go ahead and move on to color vision.
Color vision, all right, next slide. All right, so historically, for a long time, the FAA allowed 15 different color vision tests of various different types, from Ishihara, Keystone, Devoring, Farnsworth, Lantern, and the test was done at each exam. Well, okay, there was an accident a long time ago that, staying out of the politics of this, unfortunately, the FAA had to change their policy on color vision testing as far as what color vision tests were going to be allowed. So, how many problems did we have with color vision? Yeah, we saw it pretty frequently. Most times we could get them through the occupational color vision test and the medical flight test and get them to a SOTA or a letter of evidence. But unfortunately, that mishap that was quite to have some different color vision testing. Now, one thing it's important to know too is everybody thinks that women cannot have color vision problems. That's not true. It is very rare, but we've had a couple of them. And the young student female pilot comes in and says, I got a color vision problem. It's like, yeah, right, all right, sure you do. And and you're allergic to amoxicillin too. And then we run them through the color vision testing, and it's like, holy crap, yes, you do have a color vision problem. So the other problems that they had is there was concerns that people were memorizing some of the tests. Now, the Keystone testing for color vision, which we use, it only had 6 plates. I've done over 30,000 flight physicals, okay? I still can't quite remember all the numbers in the plates. I know there's a 79. Okay, I remember that one, and a 63. Okay, I remember that. But with over 30,000 done, I still can't remember. But apparently people were memorizing them. So they decided that they were going to have to change it. Now, Dr. Northrup, the federal air surgeon, to her credit, she said, look, okay, we got to change this, fine, but we're going to make sure that no one who has passed the color vision test before, or no one who had a statement of demonstrated ability or a letter of evidence was going to get grounded because of this. And she accomplished that. So we wound up coming up with 3 color vision tests, all right, of color vision tests on computer as of January 1, 2025. I will tell you, we did not have a lot of notice on this. Fundamentally, we learned about it in early December, and we had till the end of December to implement. The 3 color vision tests are the Wagner, the Ravens RCCT, this is the one that's used by the military, and the City Occupational Color Assessment. Now, 3 of these had dramatically different price points. The Wagner was by far and away the cheapest. The other 2 were pretty darn pricey, and it was justifiably hard to talk an AME that may be doing 20, 30 exams, maybe sees a student pilot, every 4 to 6 months, to spend $10,000 on a new color vision test. Quite understandable. So pretty much everybody that I know has migrated to the Wagner. There are some, we've seen a couple that do the RCCT. Now, what these tests all are what we call PIPs, or pseudo-isometric plates. On the Air Force side, when we were using these on the plates, that you had to flip, and take a look at, we had a PIP1 and PIP2, and we had to pass both of those. So that's what they look like. I'm sure everybody in this crowd has seen that before. Realistically, like I said, the Wagner was the most financially feasible, although it has gone up in price since they started it out. Now, what does it consist of? Well, I'm going to give you the Wagner because that's our point of reference, because this is what we use. The test consists of 2 sections, or 4 if you're not doing very well. All right, if you don't do very well and you start missing a bunch, it's going to take you a couple additional sections to try to define out what the problem is. We're going to test for red-green color deficiency, and we're also going to test for blue-yellow color deficiency. The important thing is, and everybody comes in and says, I'm not colorblind, or I am colorblind. Well, colorblind is an extremely rare instance. Color deficient is way more common in various different severities. All right, there are various different levels. There's various mild forms of color deficiency, and there can be isolated color vision deficiencies, such as if it's red-green, it doesn't necessarily mean that you're deficient both in red and green. You may be deficient in only one of the 2 of those. So we like not to use the term colorblind because it's not very descriptive. Now, if a new applicant comes in, and by the way, just a reminder, if you have done your color vision test before and you've passed it, you don't need to do it anymore, at least for now. That's going to be a little bit of a work in progress in the future. But if the new applicant comes in and they pass, hey, no further testing for the rest of their career. No further testing for the rest of their career needs to be done. That may change a little bit when we start getting into older pilots and the like, or various different disease processes, but that's the way it is now. If they had previously had a statement of demonstrated ability or the more modern letter of evidence for color deficiency, no testing is needed. Again, no further testing is needed. But if it's a 3rd class with a SOTA or a letter of evidence, if they want to go up to a 1st, 2nd class, then they will one time need to take that test. That's a pretty rare occurrence. We've only seen a couple of those since the first of the year, where somebody came in with a 3rd class and had a letter of evidence for 3rd class, and they wound up wanting to go up to a 1st or 2nd class because they wanted to start working on their commercial and like, and ultimately they had to take the test one more time. And if I remember correctly, they did just fine. All right, so what if they fail? What if they come in the Wagner? And we've seen a pretty fair amount of failures on these, some profound, some very mild. If they fail, one of the first things that we see before they come in and redo it again is do some practice. one of the things that we've noticed, and we don't know exactly what to make of this, is there's times we think they see the colors, but they're having a hard time recognizing the pattern, okay? So that some of this may be pattern recognition. We've even told a couple of them with your finger, and I'm going to do this in front of you, right in front of you on the screen. We've said, you know, as you're looking at the number, trace it with your finger to help you figure out what that pattern is. And then after they do that a little bit, then we retest them. And we've had a couple that failed on the first time, passed on the second. We've also had some times where they failed on both. What do we do next? Well, we have to look at possible reasons for the fail other than genetics. There are some medications which will cause the color vision to degrade. Probably the most common are the PDE medications such as Viagra, Cialis, and Levitra. There are a couple psychiatric medications which can cause problems with color vision too. The other things we have to worry about, hopefully a little bit later in the person's life, is diabetes and cataracts. That can also make the person have a problem with color vision. Ultimately, if they can't pass it, they're going to wind up with a color vision limitation on their medical, at least at the beginning. But that gets us to the next thing, all right? So when the policy first came out, the idea was that light gun test, chart gun reading, medical flight test, occupational color vision test, that was going to be gone, all right? It was not going to be available anymore. It was pretty clear that that wasn't going to work. So to get to that possibility, they realistically have got to have 2 failed tests. And then if that has happened, the request for the occupational color vision test and the medical flight test has to go directly to Dr. Northrup at DC. It has to be addressed in letter form directly to the federal air surgeon, and we have a template for that. Now, what we understand is that OCVT and the medical flight test is not a guarantee that you're going to be allowed to take it. One of the things that needs to be worked out is what we call a hard fail versus a soft fail. In other words, did they barely fail it? Is there a possibility that the OCVT and medical flight test might be passed, or did they just absolutely do horrible on it? And we've had that. Where, you know, if they do the occupational color vision test and medical flight test, it's just, they're not going to pass. They're not going to pass that either. But there are some things which still have to be worked out. Now, just some thoughts for you on this. If we get somebody who had 2 out of 25 on the red, green, and, you know, 0 or 2 on the yellow, blue, reality of the matter is, yeah, they're likely not going to be able to pass the OCVT medical flight test. This is just not going to work out well for them. And understand that it's evolving policy. Dr. Wyrick and Dr. Northrup, they're spending a lot of time with this. They're smart people, and there may be some adjustments in this policy. There was one on the Wagner already. They reduced the number to pass on the Wagner test because there was a possibility that the Wagner test might be a little bit too sensitive to finding color deficiencies. I'm not a color vision expert, but I will tell you, I still think we may be a little bit too sensitive with that particular test. But again, I'm no expert on that, and there are people who are. So let's see, where are we getting to? Oh, we're at the wrap up. Okay, a couple foot stomps, then we can take the questions. With ADHD, getting evaluated early is the key. The sooner we get to this person with a history of attention deficit disorder or ADD, the greater the likelihood that we're going to be able to issue them a medical from the field as opposed to having to go through air medical certification to do that. The foot stop with the color vision test is practice. I know that before I started having to do the PIPs with the Air Force, and before I had to start doing them and administering the test with the Wagner, I wasn't as fast. And now that I've done these things a bunch of times, I'm a heck of a lot faster with them, and I'm a lot faster at being able to recognize the patterns than I was before. So test preparation does help in that and may improve the scores. Recognize that, if the student's hard broke in either one of these two issues, you're doing them a favor by vectoring them into a different career path. The piloting may not be the right way to go, particularly when you're talking $60,000, $70,000, $80,000 worth of flight training for this person. And we've had that. We've had kids come in with some pretty significant behavioral issues where mom and dad are humoring, but this is not going to work out for them. I could give you a couple examples, but we'll skip those for this evening because we're rolling up on 50 minutes. And understand, as you well know, there are other career paths in aviation which can be just as good, which can give them a very, very nice income, keep them close to aviation. Maybe they can do sport pilot where they can use their driver's license. Recreational pilot still, if I remember correctly, still requires a medical one time, but there are other options for them. It just may not be a living flying an aircraft. And I think with that, there's some of our contact information. We do a lot of consulting. If you got cases you need consults on, we're happy to consult. We're not a free service, okay? Although we don't charge that much. There's some of the services out there that, like, for example, there's one service out there that's charging $4,000 just to work an SSRI. Yeah, I saw Aaron's eyes go whoop like that. Yeah, there's one service out there that's charging $4,000 to do an SSRI case, and they're not even the AME. So we try to stay cost sensitive. We understand that people don't have a lot of money when they're starting out in this. I know when I got my pilot's license, I sure as heck didn't have a lot of extra money to spend. But there are also other resources that you can use if you're an ALPA member or you're an EAA member. Tom Charpentier at EAA is very good at helping people out. And Gary Crump over at ALPA. Gary's been in flight medicine for a very, very long time. And Gary's and his crew there at ALPA, they're wonderful about helping people out. And those can be very cost-efficient options for you. With that, that's all I got.
All right. Well, I've got a question that relates really well. I'm gonna go back one slide on you here to that last bullet point, the last foot stomp about maybe being a pilot's just not for you. T tells us, and she doesn't give me any specifics, but I think it's still a good question. My question is, what if we have a student who has a medical certificate, but we suspect developmental issues? He was passed to me from another CFI. He's had numerous talks about the necessity of getting the basics. We've tried so many different approaches, and I truly believe it's developmental. What do you do?
Yep, we've seen that. Great, that's an excellent question. Yeah, we've seen that. And we've had I could give you some examples of late night phone calls with CFI saying my student pilot did fill in the blank. Do I have a problem or not? In some cases, no. In some cases, yeah, you do have a problem. What's your solution there? Basically, you got to make a decision whether you want to continue them in whatever stage of their training they've gotten, saying you're just not progressing. Or maybe if there's a developmental issue and it's a youngster, you might want to talk with the parents. A lot of times the parents are funding the endeavor here as far as funding their flight education. And we've done that too. I've talked with parents more times than I can think of. That's really, really your only option on that. I know that's not a perfect solution, and I apologize for that. But we have seen that where they have a medical. Again, go back to everyone can act normal for 15 minutes in a flight physical. And believe me, we've had some people with some very, very significant mental health issues that we didn't find out about it until afterwards. And again, we don't have enough time, but I could tell you some stories.
Awesome. One more good one here from Raylan. I'm an older, 63 years old, retired physician. I've been inactive for many years and I want to get back to flying. My plan was to re-enter ground school due to changes to the last flu. Medically, I do have conditions that I did not have when I last flew, and none of which require ongoing treatment. My local AME is one of the ones he doesn't upload, so I've got to mail everything and I'm still waiting. Are there any suggestions you have on how I could follow through or facilitate anything from my end?
Yeah, sorry, guy. I'm a little bit older than you, but I do recognize we do start running into problems. I've been on special issuance one time myself, so I'm very, very sympathetic to your problem. If you said you're a retired physician, shoot us a consult request on the website. We do a lot of these types of cases where we help out with that. We can probably help you out pretty easily.
Excellent. And you've alluded to this already, but I know you're not watching the chat, but I'm being told that there's just all kinds of conversation there about lots of specific cases and situations. And I'm sorry I can't sit here all night, or I would, because I know Dr. Pinnell would have something for everybody, but I also wanted to be careful and respectful of the topics that you wanted to talk about and try to keep it as germane as I could. But just reiterate, if you would, real quick before we sign off, if they're on that chat right now or watching and they think, I've got this thing, a heart thing, blood pressure thing, whatever, and I need some help, run back through the options in terms of obviously your service, but who else did you say again would be good to talk to?
So what you really, really have to do is recognize, and I say this in the nicest, most respectful way, not all AMEs are the same. A reasonable amount of what we do on a daily basis is cleaning up cases for other AMEs on special issuance conditions. So you've got to find out who's willing to work with you, B, who is competent to work with you and knows enough about, goes to all the conferences. We go to 4 conferences a year to try to stay up with policy. And that's when we're not talking with FAA and the various different people in there. So you've got to find someone who's willing to help you. We don't necessarily suggest you look through the AME guide. The AME guide was written for physicians. It can be somewhat helpful, but it can also be a lot confusing too. And sometimes it confuses the pilots more than helps. You've got to check your resources. Some services are more expensive than others. And unfortunately, sometimes that depends on your financial resources. But really it comes down to finding an AME who knows how to do this and is willing to spend the time to do this, even if it's paid.
Okay, thank you. Last question, I promise, is from this guy of questionable intelligence named Aaron Dabney. There's a lot of instructors tonight, so I want to leave with a point that we can take away and use in our day-to-day work. If you could give me as a flight instructor one tip that would help my customers maximize their time with their AMEs and make it a favorable experience for them, because I know we can't guarantee a favorable outcome, but a favorable experience, what would you tell me?
If there's any question on the diagnosis of pre-consult, we have whole days that we do T's, what we call T's, telephone consults at 30-minute intervals, and a lot of times doing that T will grease the skids very nicely to allow the person to be able to get the documentation that we will need. Or sometimes we'll find out, they'll go through the, I got this, you got that, and they're going, okay, so what am I going to need? Nothing. Come in the office. None of those are aeromedically relevant. I don't need any documentation on any of those particular diagnoses. We run into that one on a pretty regular. I particularly will get that one at EAA when I do forums. Somebody gets up the microphone. I've got a hangnail. I've got toenail fungus. I've got a rash that's resolved. What documentation am I going to need? And you're just kind of like, nothing. We're good. Okay. So do a phone conference first. That's the thing that will help if you have questions.
Thank you. Well, Dr. Pinnell, we can't thank you enough. This has been really valuable. And, like I said, when you first brought this up at Oshkosh and you mentioned these two particular topics, I thought, yeah, people want to hear about that. So I know this has been really useful. So thank you again so much.
Pleasure's all mine. It's been a blast, and hopefully we've given them some information.
Excellent. So I want to encourage everybody, go ahead and mark it on your calendar now. I know it's getting really close to Christmas, but December 17th is going to be a great night. We're going to have Sean Elliott come back from EAA. Actually, Dr. Pinnell mentioned Tom may be here as well, but we're going to kind of update you on Mosaic. When Sean was here earlier this year, Mosaic was coming, and now it's here. So we want to give you a good deep dive on how we as flight instructors and flight school owners can leverage that. So make sure you're here for that. And it's not lost on us that that's actually Wright Brothers Day that we're doing that on. So how cool is that, talking about Mosaic on Wright Brothers Day? So make sure you're here on the 17th. Don't forget, go take that quiz. It'll take you like 2 minutes because you got this down, right? Get that certificate, get your wings credit. And don't forget, if you're not a NAFI member, that'd be a great early Christmas gift to yourself, right? Join NAFI if you're not a member. We'd love to have you among our member. One more reminder, if you haven't had a chance to look at some of that free content from the first NAFI Summit in 2023, I'm telling you, it's a gold mine. Go mine it for yourself. Good stuff there. So with that being said, we'll go ahead and sign off for this month. We'll see you next month for MentorLIVE number 99. Y'all have a great night.